we have been management by Dr. Simant Kumar. He is senior consultant of anesthesiology in the ICU in PSRI Hospital in New Delhi, India. And he's talk about the pain management in burns patient. Welcome, Dr. Simant.
Thanks a lot, sir, for giving me this opportunity. I will be talking about pain management in burn patients. It's a difficult thing to control pain in cases of burn. Burn wounds are extremely painful, as we all know. And despite significant recent advances in the treatment of burn patients, still we are not using adequate analgesia to control pain. And because of this, the complex nature of pain presented by these patients and insufficient training of the professionals involved, pain management is still, pain is still, we are not controlling pain properly. And I will be talking about the pharmacological and non-pharmacological approaches. Often, burn wounds are painful, at least initially, and the degree of pain varies depending upon the depth of burn wound, either first degree, second degree, third degree, and fourth degree. Superficial partial thickness burns result in hyperalgesia, leading to mild to moderate pain. Moderate partial thickness burns are associated with marked hyperalgesia and produce moderate to severe pain. Burns at this depth injure or inflame sensory receptors in the dermis. Basically, I'm talking about the characteristic of the burn pain. What inadequate pain control will do? If you are not giving adequate analgesia, it will have negative effect on the patient. Patient can have chronic pain. Patient will have paresthesia. Patient will have dysthesia. And there is association between psychiatric disorders. If the pain is not getting adequately controlled, patient can go into depression and post-traumatic stress disorder. It includes the pain, basically the pain management team should be including your pain physician, your pharma nurse, and your physiotherapist, the psychologist, everyone. Everyone has to be involved to control the pain. Multidisciplinary approach to these patients is critical due to the complexity of factors involved in the pain. Analgesia requirements may be varying because of the numerous procedures that patient undergo, as well as their evolving condition. Coming to the mechanism of pain, we should know burn is due to direct stimulation and injury of the nociceptors present in the epidermis and the dermis, leading to transmission of nerve impulses by A delta and C fibers to the spinal cord dorsal horn. This impulse magnitude is getting modulated by both the peripheral stimuli and the descending influences from the brain. Quality of pain may change as the inflammatory responses subsides, but pain intensity may vary. Typically, it's maximum in places of skin loss and tissue donor areas. In case of severe burns, the initial destruction of nerve endings leading to local intensity to pain. In these areas, there may be discretely regeneration of nerve tissue, which might predispose to neuropathic pain. And we all know controlling neuropathic pain is a difficult task. It is estimated that up to 52% of burn patients have chronic pain. How to evaluate? There are so many scales we are using, like visual analog scale, verbal descriptive scale, and faces and colors scales are used. There are also behavioral observational scales validated for use in patients who are unable to express themselves effectively. And we also use FB pain scale and FLAC score for young children, but I'm not going to discuss about them in detail right now. 4 patterns of pain have been observed in burn patients. One is your background pain, where the patient will be complaining of constant pain at rest and in motion, aggravated by episodes of intense and sudden pain, that is breakthrough pain, pain occurring during procedures, and pain in the post-operative periods. how to approach burn pain management. One is your pharmacological approach, where we can use both opioid and non-opioid, and the other is non-pharmacological. For opioids, basically we are using morphine, fentanyl, alfentanil, and remifentanil as per the availability and the resources. Normally, we are not getting remifentanil and other things. Anti-inflammatory drugs, paracetamol and dipyron we can use. We can also use, and we are using for the neuropathic pain, gabapentin and the pregabalin. Antidepressants like amitriptyline, SSRIs, we can also use, but pain control for them is analgesic effects takes weeks. Ketamine, a simple anesthetic agent, that is wonderful drug we can use for controlling pain, for controlling hyperalgesia, and we can combine it in combination with opioids, where the doses of opioids will be reduced, or we can combine ketamine with other drugs also. Benzodiazepines like midazolam, dilorazepam, and other agents can be used either in combination of opioids or the ketamine. Lidocaine also have been extensively used. Clonidine, both alpha-2 agonist and the dexmedetomidine have been extensively used, because clonidine, basically it is analgesic, it is having analgesic property, it also reduces your blood pressure, and it is sedative too. Three properties both clonidine and the dexmedetomidine is having. So we can combine all these drugs as per the availability, as per the patient requirements. And for using these things, first important thing is we must know what is the mechanism of pain, what sort of pain it is. We use our visual and analog scale and other scales for which agent has to be used. Opioids, basically they are being used to control the background pain in burn patient in moderate, and should be treated more appropriately with moderate potency drugs whose plasma concentration remains relatively constant throughout the day. That's why sometimes we are using patches also, like fentanyl patch and other things, and getting morphine every time is not easy. That's why we can use fentanyl, alfentanil, remifentanil, whatever is available. Most commonly, the how to use intravenous opioid infusion we can use with or without. If the PC is available, that is the best thing. If it is not available, through infusion or IV, we can use. Long-term opioids like methadone can be administered orally, or as it has prolonged internal absorption, opioids, controlled release morphine or oxycodone can be used. Tramadol and opioids, they are promoting a beneficial effect in neuropathic pain. As far as the literature is concerned regarding which one is superior, opioid for neuropathic pain treatment, there is still no evidence. Remifentanil and opioid with ultra rapid onset and plasma metabolism is a good option for analgesia during procedure when delivered by continuous infusion. And we all know this is very fast acting and is short acting also. Fentanyl and alfentanil can also be used with advantage of promoting residual analgesia. And we know that fentanyl is easily available everywhere. Anti-inflammatory drugs, paracetamol, that is most commonly used drugs, as we can use them. Suppose the burn patient is having comorbidities like CLD, CKD, and those chronic liver disease patient and other things, we cannot use other agents like your NSAIDs, even opioids that much. For that time, up to 2 grams of paracetamol in 24 hours will suffice. So paracetamol is still, though it is not having that much analgesic property, but it can be combined with other agents, with opioids also. And basically, when are using these agents, they decrease the opioid need by 20 to 30%. As far as the NSAIDs are concerned, may also reduce the adverse effect of opioids significantly. That has been seen. And cyclooxygenase 2 inhibitors, dipyron and paracetamol have been extensively used. We all know when alone paracetamol, other drugs cannot give you proper analgesia. That's why synergistically they have to be used with opioids. And we know that NSAIDs have to be avoided whenever there is a less platelet count, PTs increase, and there are chances of bleeding. So we have to be very, very careful in patients, those who are having bleeding tendency, especially the chronic liver disease patient and the CKD patients. We have to use these NSAIDs very, very judiciously. In patients with cardiovascular and gastrointestinal disease, NSAIDs, we know that they can cause your MI and other things, because they can cause your platelet aggregation leading to thrombosis. So we have to use them very judiciously. That's why we tell that whenever using as an NSAID, the patient should be properly hydrated, and there will be lesser acute kidney injury incidences if the patient is euvolemic. Antidepressants, they are effective drugs, and they are playing very important role in the concept of multimodal treatment of pain associated with burns. Amitriptyline, if used in low doses, has established is a wonderful agent in the management of neuropathic pain. 25 mg tablet normally is coming. And how it acts? By activating the descending inhibitory pathway in the spinal cord. Dose is not more than 75 mg per day. The only problem is that has to be used for a longer duration. Selective SSRIs may also be used in cases of intolerance to side effects of tricyclic agents. As I have told before, the analgesic effect of antidepressant usually occurs within days or weeks. And still, there are no studies regarding the analgesic effect and time to start analgesic therapy in burn. Ketamine, again, quite available agents and good anesthetic agent. And the meta-analysis that has been done at low doses and post-operative consumption of opioids, the author conclude that there is reduction of up to 1/3 in total doses administered. So if it is getting combined with other opioids, the doses of opioids are less. Ketamine is effective as a rescue medication in case of painless, less responsive to opioids. Means if the patient, even after giving opioids, is not responding, we can use low-dose ketamine. And ketamine appears to promote some actions in reducing hyperalgesia. As far as the benzodiazepines are concerned, the burn patients who benefited most from therapy with benzodiazepines, if they are very much anxious or having severe pain, we can use midazolam, we can use lorazepam, and we all know midazolam has got rapid onset of action. Lorazepam is more suitable than diazepam because diazepam is very long acting and it has got just byproduct desmethyldiazepam, so it should not be used. Lorazepam, it doesn't get accumulated in liver. It has got decreased hepatic metabolism and often present, which may prolong the half-life. So lorazepam can be safely used, and including your midazolam. Lidocaine, IV lidocaine has been effectively used in reducing neuropathic pain associated with nerve injury. However, a clinical study is showing only a small difference in pain scores requiring opioid maintenance doses during burn patients' dressing changes, but still lidocaine has been safely used. Alpha-2 agonists are concerned, we have got two agents, clonidine and dexmedetomidine, have interesting properties that facilitate their use in analgesic. It has got good analgesic property, and I told before, it has got causes vasodilatation, so decreases the blood pressure, and it also causes sedation, besides stimulating the descending inhibitory pain pathways. Clonidine may be used safely in analgesic management of child burn victims, as it has got excellent analgesic effect. And in some burn center, it is routinely prescribed for children and adults. As far as the dexmedetomidine is concerned, it has a shorter duration of action than clonidine, and its action is more selective compared to the other alpha-2 receptors. One study has shown that positive result in association between ketamine and dexmedetomidine compared to ketamine alone or in combination with midazolam during dressing changes in burn patients. Means if we combine drugs, there is a wonderful effect and the reduction of the in dose of the other drug. Uses of cannabinoids, due to lack of evidences, and the potential legal and political obstacles, we are unable to make a recommendation for the use of cannabinoids in the treatment of acute burn pain. So it can be used, but it is widely used, and substance abuse because of this. So this is level D recommendation. So it's not available everywhere, and because of its substance abuse, it's not recommended. Regional anesthesia is concerned for burn patient management, has the potential to provide improved pain relief and patient satisfaction, and dose of opioid is getting reduced without serious risk or complications. It has got level C recommendation. So we can use regional anesthesia whenever, suppose that part surgery has been done or something like that, you can put catheter, you can infuse your through catheter, the drugs can be administered. So adequately, you can control the pain. What is new? We all know we have got patient control analgesia. And one study that has been taken from your foremost medical association in 2010 paper, this has been in European publication, patient control analgesia for background pain of major burn injuries. At the McKechnie Memorial Hospital, a retrospective analysis from June 27 to October 31st of 2015 was carried to investigate the use of IVPCA in relation to the demographic and clinical data of patients who suffered from the burn injuries due to the massive explosion of a flammable powder. So it has been, because we know that PCA has been used extensively, even in the wards, it can be used. It has been used before and is getting used. Only it should be, patients should know how to operate it, or the nurses or who are there at the time, they must be knowing if there is something wrong. So it is a wonderful thing. This one, patient control analgesia. So that study was done, and it was a standardized morphine IV PCA protocol with rapid escalation was implemented. Variables were age, weight, gender, days of usage, total surface area burned, and operations. What was the result of the trial? Among the 23 patients who received IV patient control analgesia for burn patient control, it was noted that larger the total body surface area of the burn and the higher the visual analog scale, the more amount of morphine was consumed. Correlations were made between morphine consumption. It was positive with weight. The p-value was less than 0.01. Female gender p-value was less than 0.01, and severity of injury, and negatively with receiving operations were statistically significant. So what was concluded? It was concluded morphine consumption was positively correlated with total body surface area of burn, visual analog scale, weight, female gender, and use of our IVPCA protocol was sufficient in the management of background pain for patients with major burn injury. Now coming to the non-pharmacological treatment, non-pharmacological therapy is as important major complement to the medication to manage pain patients and anxiety, because we all know the burn patients are having anxiety because already they have suffered that much. They can have post-traumatic stress disorder, they go into depression. So the nurses, the doctors, the psychotherapists, the physio, everybody should be talking to them, and they should be consoled. Things will be okay, and the whole team should be working cohesively, and the things should be initiated as early as possible in order to prevent the development of anxiety. That's why before controlling anxiety, pharmacological managements, we have used that SSRIs, then tricyclic agents, amitriptyline. So basically, when we are talking about the non-pharmacological treatment, we have to talk to them, we have to consult them, and especially the role of psychologists, the role of other doctors, the psychiatrists are very important. Approach should be always multidisciplinary, involving psychologists. You have to involve your psychotherapist, you have to involve your physiotherapist and the pain specialist. The physiotherapist role is, these days are increasing, as we know that drugs, they are having side effects. So regular physiotherapy of the legs, the contracture can develop. The patient will have to undergo surgery. If the physiotherapy is done adequately at the regular intervals, the things will be different. Psychological techniques like your relaxation, your distraction, cognitive behavioral therapy, your yoga and all, if the patient is able to do your pranayama, and that are much beneficial for relieving anxiety and pain during rehabilitation, because not alone this non-pharmacological, you have to combine pharmacological therapy with the non-pharmacological therapy for adequate control of pain. But at the same time, whole team should be working cohesively, including your psychologist and physiotherapist. Hypnosis is an altered state of consciousness characterized by increased receptivity to suggestion, ability to change perceptions and sensations, and increased capacity for dissociation. So if the hypnosis can be done, the patient has increased receptivity to the suggestion, he will listen to you more, he will have changed perception, he will have changed sensation. It has been effectively used in managing pain in burn patients during procedure and to control anxiety. And all neurophysiological studies are supporting this therapy. So hypnosis can be a wonderful therapy as far as the non-pharmacological therapy is concerned. Virtual reality. What is this virtual reality? This is another approach used very successfully. It consists of a technology that isolates the patient from the real world, letting his vision only in contact with a three-dimensional virtual environment. In this context, this virtual world is called the snow world, especially created to counter sensation, most commonly caused by a burn injury. And in some studies, virtual reality used as a technique of distraction during procedure was effective in reducing the intensity of the pain. Basically, whatever technologies, whatever therapy you are doing, we have to distract the mind of the patient. We have to dissociate the patient from the real world. And in this case, the patient is in the virtual world called the snow world. So what is getting concluded? The pain management in burn patient remains challenging. Despite that, even for the multidisciplinary team, and frequent and continuous evaluation of the patient response is very important, because you cannot leave the patient like that once you have treated the patient. Sometimes patient is altered sensorium, sometimes the patient is having sepsis. You have to be continuously talking to the patient due to the various, and especially the hospitalized burn patients, as well as combination therapy, both analgesic and non-pharmacological measures have to be combined. Understanding the complexity of the pathophysiology that I have talked before, the psychological and the biochemical changes presented by a burn patient is the first step to achieve success in analgesic management. Thank you.
Thank you so much, Dr. Simant. And we have one question here from Dr. Viking. Can we use remifentanil during burn dressing?
Sir, it all depends on, as per the, sir, it can be used, sir, during burn dressing, but you have to be very careful what setting and what hospital you are working. As far as it can be used through infusion, it can be used. It is short acting and very rapid onset of action. It can be successfully used, but it depends on which hospital. If it is a tertiary center, everything is available nearby, then you can be used. Not in the primary center, and it all depends on its availability. It can be successfully used, sir.
Yeah. Actually, if some patient need the daily dressing, especially in pediatric patient or something like that, so for the short term of remifentanil infusion during the dressing, it may cause hyperalgesia, or what do you think?
Yeah, it can cause, sir, for this one pediatric patient, it should be avoided, sir. As far as the pediatric patients are concerned, because we don't know remifentanil infusion, and I don't have that much sir, experience of using in pediatric patients. Exactly, I cannot tell you, but it should be avoided in pediatric patients.
All right, yeah. I saw some articles about using the oral ketamine, especially in pediatric patients.
Yes, sir. Yes, sir. Oral ketamine is a wonderful drug. It can be used, sir. oral ketamine, because once you don't have oral ketamine tablet, we can also give IM ketamine to the pediatric patients. You know that absorption will vary up to, so oral ketamine tablet can be used successfully.
All right. Again, it can be used as a daily basis. Patient need daily dressing and the care of the wound.
Yes, yes, sir. Because yes, sir. Because we all know that absorption and the bioavailability is not going to be that high. It will take time. But oral ketamine you are giving, wait for some time, let it be absorbed. Then you can think of this. Nothing like that you have given, and it will start working, because bioavailability is not like the IV. So you have to wait for some time.
All right. Thank you so much, Dr. Simant, and thank you for all the speakers and the attendance today.